Hey there, welcome to our video. Today, we're going to take a closer look at a research paper that explores the connection between familial Alzheimer's disease and small vessel disease. Method: Human subjects. Table 1 shows the demographics and relevant clinical and pathological features of the 88 subjects. The PSEN1P.GLU280 genealogy was identified 30 years ago, and carriers were regularly followed up using the SARID protocol, NINC-ZDRA, and DSM-4 criteria until end-stage dementia and death. We searched the neuroscience group of Antioquia, GNA, database for subjects with confirmed positive genetic status for P.GLU280 in PSEN1 or any mutation in the Notch3 gene that would have been evaluated using imaging during their follow-up and would have donated their brain for research. A total of 31 cases fulfilling these criteria, 21 PSEN1 FAD and 10 CADASIL subjects, were selected for the study. The PSEN1 FAD subjects were chosen to be representative for the P.GLU280 family. We also assessed 12 CADASIL subjects from the Newcastle cohort and 28 SAD cases from both the Colombian and Newcastle centers. There are no AD cases in the family history of the SAD patients. Unless otherwise stated, for further analysis we considered the CADASIL and SAD groups from the two centers as two combined respective disease groups, since there were no significant differences in age, gender, brain weight, or vascular risk factor distribution. In addition, we assessed brain tissues from 17 old and 10 young controls to match all the AD and CADASIL subjects. For the purpose of this study, we considered the SAD cases to be the positive control for AD-related vascular pathology and CADASIL cases as the positive control for brain SVD. Brain donation and procedures were performed following the ethical approval from the respective institutions, Universidad de Antioquia, Medellín, Colombia, and Newcastle Health Hospitals NHS Trust, Newcastle, and informed consent from the patients or family members. Results: Characterization of PSEN1P.GLU280 FAD, SAD, and CADASIL patients. There were no age of onset or gender differences between the PSEN1 FAD and the comparison group of CADASIL subjects. As expected, SAD patients showed statistically significant older age of onset, but there were no gender differences. Disease duration showed no significant differences between the three groups. Both PSEN1 FAD and CADASIL groups tended to have high frequencies of vascular risk factors, including that acquired by behavior such as tobacco smoking, compared with SAD subjects. There tended to be a greater frequency of tobacco smokers in the Colombian subjects. While there were no overt stroke events recorded in the PSEN1 subjects, greater than 90% of the CADASIL subjects had at least one stroke. Where longitudinal follow-up data were available, we found that both the PSEN1 FAD and CADASIL groups showed a significant decline in cognitive performance over time. On comparing the trajectories longitudinally between both the groups, controlling for age and education level, the PSEN1 FAD group presented with significantly lower performances in the cognitive domains of memory and reasoning. The severity of the decline in cognitive impairment in general, and in specific cognitive domains, was significantly higher in PSEN1 FAD than in CADASIL subjects, with the sole exception of a decline in executive function which was not significantly different between groups. On the other hand, the rate of cognitive decline was similar in both groups with no significant differences. T2W or FLAIR MRI scans of the PSEN1 FAD and CADASIL patients from Colombia were graded for WM changes using Fazekas scoring. 9 out of 21. 42.86%. PSEN1 FAD subjects showed mild WMHs in contrast to the Colombian CADASIL cases who showed significantly higher scores, as expected. Available CADASIL cases, N equals 6, from Newcastle also all showed high scores, that is, 3 with presence of both periventricular as well as deep WMHs on T2W or FLAIR MRI. Further, we assessed imaging patterns in both groups. PSEN1 FAD subjects showed evidence of mild to moderate brain and cortical atrophy according to different grading systems, while CADASIL cases showed higher frequency of cerebral microbleeds than PSEN1 FAD cases. Assessment of vascular pathology in PSEN1P.GLU280 FAD, SAD, and CADASIL. Mean brain weights of PSEN1 FAD cases were significantly lower than those from SAD and CADASIL cases. Upon neuropathological examination, the entire spectrum of vascular changes including small infarcts, microinfarcts, hemosiderin leakage, arteriolosclerosis, and WM attenuation was evident in PSEN1 FAD subjects. We observed that every PSEN1 FAD subject had at least one lesion attributable to vascular disease. Although cerebral microbleeds were not seen upon MRI in PSEN1 FAD, we noted the presence of some perivascular hemosiderin leakage in these subjects as well as in CADASIL subjects. To determine the degree of SVD in FAD, we quantified cortical and subcortical vascular pathology in PSEN1 FAD compared with SAD, as a control for the possible role of CAA in SVD, and with CADASIL, as a positive control for SVD and dementia. The average scores showed that PSEN1 FAD was similarly affected to CADASIL in frontal and temporal cortices together with basal ganglia. Both PSEN1 FAD and CADASIL scored significantly higher than young or older controls. SAD cases, on the other hand, scored significantly lower than CADASIL cases, and significantly higher than young healthy controls but not from controls of similar age. Lack of differences between PSEN1 FAD and CADASIL remained when all cortices and basal ganglia were evaluated in PSEN1 FAD cases and a subset sample of CADASIL. We also noted that WM attenuation was variable between FAD, SAD, and CADASIL subjects and presented no statistically significant features when measured. We further found that although the degree of arteriolosclerosis was not different in FAD and SAD, CADASIL as expected had greater numbers of arteriosclerotic vessels. These results suggest that SVD is common in PSEN1 FAD pathology. Lack of association between CAA and dilated perivascular spaces in PSEN1 FAD. CAA in AD cases was evaluated as another feature of SVD. We found that both AD groups exhibited similar numbers of CAA-affected vessels in all evaluated cortices for all categories of vessels. Next, we quantified the size of enlarged PVS in PSEN1 familial, SAD and CADASIL, as enlargement of PVS is another feature of SVD. The ratio of PVS according to the diameter of microvessels with and without CAA in A-beta stained occipital cortices were quantified in both FAD and SAD cases. Likewise, PVS ratio was assessed in occipital cortices from CADASIL subjects using hand staining, given that CAA is not a pathological feature of this disease. In general, PVS was significantly enlarged in non-CAA vessels in FAD cases. This difference was still evident in vessels of both less than 50 micrometers and 50 to 90 micrometers diameters. This could not be confirmed for vessels with a diameter greater than 90 micrometers because the tissue sections did not contain sufficient large numbers of vessels of this size. Finally, we found a positive correlation between enlarged PVS in non-CAA vessels and the severity of the decline in MMSE scores in FAD cases, although these variables were unrelated in CADASIL. The lack of differences in CAA pathology between AD groups and the presence of significantly dilated PVS without CAA pathology in FAD support the notion that SVD type of arteriosclerotic changes independent of A-beta pathology occur in PSEN1 FAD. So, there you have it, a fascinating glimpse into the world of Alzheimer's disease and small vessel disease. If you want to learn more about this groundbreaking research, be sure to check out the full paper. Thanks for watching, and stay curious.
Pharmapal. Pharmapal.